JP Brito, endocrinologist at Mayo Clinic, and thank you for having me here in your congress. It's a pleasure to be here. I'm gonna be talking about artificial intelligence and thyroid nodules, and new weapons. In case that you want to reach out with questions or comments and we don't get to talk today, this is my email and my Twitter handle. I have no disclosures for this presentation. Before we start, this is where we are in terms of the applications for artificial intelligence in thyroidology. This is a systematic review that we conducted the last year with our team here. And on the left, we're showing all the studies on artificial intelligence in thyroidology between 2018 and 2022. And as you can see, has been a significant increase in the number of publications about artificial intelligence in thyroidology, with the most part being in the area of thyroid nodule and thyroid cancer, which is the area that we're going to address today. But more importantly, here in the graphic on the right is that despite having so many publications on the topic of interest, only few of those publications or products or tools had been adopted or had been passed what is called utility testing. The vast majority of these AI tools still live in the validation space, and this is important because as we go through our presentation today, I will be telling you the potential of AI. Some of those AI tools are already available for us in practice, some of those AI tools available for the future. Why is it important to talk about AI? Because we have significant problems in the field of thyroid nodule and thyroid practice, this being one of the most important ones. In summary, there is a significant shortage of endocrinologists in the world. This is a graphic that shows the United States. The areas in blue is when the patient can find a doctor within 20 miles, and the areas with no color are areas in which we don't have actually an endocrinologist that can access. So what that means is that the majority of care that patients will receive for thyroid nodule thyroid cancer will be by primary care physicians or physicians who are not experts on thyroid nodule and thyroid cancer. So there is a need to support the practice of these physicians, hopefully with some AI support. The second problem that we face in the management of thyroid nodules and thyroid cancer is a reliability crisis. What that means is there is significant inter and intra-observer variation when we deal with thyroid ultrasounds, when we deal with cytology, and when we deal with pathology. And this means that if we were to ask two radiologists to comment on a particular nodule, it's quite likely that the two radiologists will have a different opinion about the thyroids or the features of the nodule or the Bethesda or the kind of the characteristics of the cancer in the histopathology. So we have been facing this problem for a long time, and AI might have an opportunity to help us here as well. And finally, the third problem in the field of thyroid nodule and thyroid cancer is that we don't have data sets and registries. This is the picture I'm showing you in these slides is one of the most comprehensive registries of thyroid cancer in the United States. It's called the SEER program. And as you can see, the SEED program includes only few states out of 50 states in the United States, which means that the majority of patients with thyroid cancer will not be included in this data set. In fact, we don't have a data set for thyroid nodules, so this is only for thyroid cancer. And for those patients who are included, we're missing a lot of important data. And it is only captures a very specific amount of data. We don't have, for instance, recurrence rates and treatment that patients receive. So it's difficult to understand the effect of treatments, effect of surgery, or type of surgery on the care of these patients when we really don't have registries or data sets. So another potential avenue where AI can certainly help us. So let's navigate some of the things that we can do now, maybe in the future with artificial intelligence for the management of thyroid nodule and thyroid cancer. Let's start with Dr. Torres, who's seen a patient with cough and does a CAT scan of the chest. And as many of you probably have been facing, the CAT scan shows a thyroid nodule. And this is the nodule here in the left part of the thyroid. And of course, we are not that good at identifying whether that nodule is suspicious or not in the CAT scan. In fact, the guideline says if you have an incidentally found thyroid nodule, you have to do an ultrasound because we humans, we cannot really distinguish whether something is malignant or benign just in the CAT scans, and we do the ultrasound. And the nodule that is shown here is actually a mostly cystic nodule, but incidental in the ultrasound, in the contralateral lobe, there is a small suspicious looking thyroid nodule. It's very typical to have these events, incidentally noted nodules in the CAT scans. We do ultrasound, and in 50% of those patients with ultrasound, we ended up finding more nodules than we were expecting. And of course, that drives a lot of the what is called overdiagnosis of thyroid nodules and thyroid cancer. So what is happening in the near future is that we're going to be developing systems in which we can maybe use just the pictures of that CAT scan as opposed to requiring everyone to do the ultrasound. We might be able to use the CAT scans to accurately distinguish between nodules that need to have an ultrasound and nodules that are very unlikely to need an ultrasound. So the way this works is the systems will find the nodule. So these are several images of CAT scans in which the AI tool is finding the nodule, and then it runs what is called feature detection. So detects features in terms of the shape, intensity, vascularity, heterogeneity of the tumor, texture, and many factors that humans we cannot really see. And then it runs a machine learning model, so an AI model, that will be able to tell us whether it's something more likely or less likely to be cancer. So for hopefully this will be soon in the future. We are actually developing one system here in Mayo Clinic that we think we're going to have it ready for the next year. Now, let's see that Dr. Torres, of course, has to do the ultrasound. This is a system, it's called the CAIO system. These are one of the tools that are already approved by the FDA in the United States. And what it does is in a typical ultrasound pictures, we can annotate where the nodule is, in this case, a transverse view, a longitudinal view of the nodule, and then run analysis of this nodule. And then it will tell us based on thyroids, the features, and the overall score. You can continue on the same process with a second nodule. In this case, this is a transverse view, and this is the longitudinal view. And as you can see, it's actually very accurate. This is very likely to be an indeterminate looking nodule. It can show this, the analysis, and then it can actually show where the nodule would be located. So at the end of the process, you will have a report like this: the nodules, lead location, which one is more suspicious, which one is recommended for biopsy based on size, and the thyroid system. So in doing so, the system helps a lot with the reliability on the measurement, meaning that if we were to run it again, it's quite likely that we get consistent results. What I like about this system is that reports not only this outcome of what is suspicious or not, but also describes why it's suspicious or why it's not suspicious, so one can review that. In addition to that, the systems right now can create this 3D mapping of the nodule. For instance, here, this is also a system that has been approved by the FDA. In this particular nodule, you can see the nodule and you can see where the nodule is inside the lobe. And I think it has potential in informing decisions in regards to surgery, as well as, for instance, decisions in regards to monitoring small cancers, that whether or not it's located close to the nerve or close to the trachea and so forth. So I think the location will be mostly 3D in the future too. Now, what I find interesting is that some people are developing these systems, again, AI, deep learning approaches. What they do is they have a visual representation, again, a 3D visual representation when the nodule is, inform surgery, and then they can actually print that in a way that is a 3D printer, in a way that they can inform decisions with the patients in regards, now, this is your thyroid, this is where the nodule is, and this is what we're going to do with surgery. In fact, the study I'm showing here, they use it for informed consent, which I thought it was an interesting way to use this technology. Well, we have a nodule then that is probably found in the CAT scan, followed by ultrasound, and the Dr. Torres has this information in the ultrasound that says, of course, it's highly suspicious. But in the future, we will have way more information from ultrasounds. And the reason is that so far, the ultrasounds are focusing on the features of the nodules, but there are already different systems that can actually recognize not only the features, but can somehow now distinguish between whether it's going to be a papillary, follicular, or medullary. The mutation of the tumor, mostly the systems have been developed to detect BRAF, still not mutations like TERT, other more aggressive mutations, but they are getting to that point. And I think the systems that we want to develop here, for instance, is to predict to what extent we can know which nodules are going to grow if they were to be watched, or for instance, just by looking at the rest of the parenchyma, whether the patient will have hypothyroidism and even more systemic conditions like Alzheimer and Parkinson. Because again, the machine can see signals that we cannot see. We know that from studies of retina scans, for instance, they can already detect patients that might have some degenerative diseases, central nerve diseases, or even systemic diseases like diabetes and things like that. So it's quite likely that the ultrasound in the future will give us more information than the typical characteristics of the nodule. So the nodule is highly suspicious. Dr. Torres does a biopsy and, of course, shows atypia, a typical finding, has another biopsy, and it becomes benign. Patient goes to have a third opinion in another place, and it becomes suspicious. And it's not uncommon to have this scenario. And the reason is that if you get to ask 3 different pathologies, they might not always agree on what they are seeing. But the machine will be able to support that. In fact, there are accurate systems right now that can already diagnose the category of a TESDA and can actually tell with 95% accuracy right now whether something is benign or malignant. And in fact, they can also detect mutations. The question is why we are not using those. One is because they still need to be tested in a very large number of patients. So far, the tools that I have been showing, particularly the ones that had not been FDA approved, are systems that had been tested in a very small set of patients, but they have significant potentials. The patient goes to surgery, we have the pathology here, and so far, this is the typical report we get. Now, in the future, we're going to get not only that, but we're going to use 3D pathology, digital pathology, and we're going to be able to tell whether the cancer that we're seeing actually is a high risk, low risk, and whether it's going to respond to radioactive iodine, for instance. So we're going to acquire that predictive and prognostic power as well. So far, in terms of the data sources that we have for thyroid nodules and thyroid cancer, we are just really scraping the surface here with some of those data sources. For instance, the digital pathology that I'm mentioning right now. But the AI will open a series of other data sources that we have not yet uncovered. For instance, the tumor microenvironment and other biomarkers, metabolomics, the power of liquid biopsy, which to some extent is already happening, protein biomarkers, gene biomarkers, and put them everything together in multimodal systems that can tell us more about the biology of that particular cancer or tumor, or even thyroid nodule. So that, I think, will change our field in the future. Now, Dr. Torres wants to show the students that he found this incidental thyroid nodule in his practice, but he wants more thyroid nodules like this so the students can learn about how do they distinguish between a suspicious thyroid nodule versus a non-suspicious thyroid nodule, goes to Google, checks in the internet, doesn't work. It's very likely that the AI systems will help us with this too in educational purposes. So right now, for instance, it's relatively easy to run a test image of a nodule and look back in a data set of images in the institution, similar nodules, similar features, so we can pull those images to our files and show our students which nodules that we have seen over the last 10 or 15 years are similar to the ones we're seeing right now, and what could be the outcomes of those particular tumors. So the students, they don't have to wait a month, 2 or 3, 6 months to see a pathology. They can experience the whole cohort of patients that have been seen in an institution at once. So there is a lot of condensed learning that can happen once we implement the AI. Dr. Torres is seeing the patient after surgery, and is talking to the patient and is a little bit overwhelmed because he has to see many patients that day. He wishes that somebody can take notes for him when he's talking about the plan for the management of thyroid cancer for this patient. There are systems already implemented in different healthcare systems. Here, for instance, we have one already running, and many other healthcare systems in the United States have what we call the AI scribes. These systems, what they do is in the interaction between the physicians and the patients, the phone captures the recordings, and with a large language model that is focused in summarization, we'll have an output in which describes everything that has been discussed and captures actually the plan of care as well. So that could be easily integrated into the system that we use to, file and store these kind of conversations. So the doctor has to be worried about paying attention to the patient rather than paying attention to the documentation. So that is already happening. Something that I find quite interesting as well is that these systems, for instance, and these are available, for instance, this comes from an AI chatbot that is called Doximetry here in the United States, that is for physicians. You can ask the system to give you plans of care that you can use in your notes. So this is a plan of care that the system has actually drafted for patients with a medullary thyroid cancer, very nicely done, very accurate about the initiation of TKIs, so medicine for these patients. And you can actually use that to translate it to the patients in a way that they can understand the recommendations and the language. So that is very easy to do. I'm not recommending everybody doing it because, again, those systems don't always keep the private information. But if you keep the names and some identifiers out, you can actually do a little bit of this in the extent as long as you keep it private. Dr. Torres is the patient, has the documented ready, but patient staff do have questions, and many patients have multiple questions. And one of the things that overwhelm us as clinicians is, there are many, many questions in the systems, the communication, and we don't have enough time to answer. So this is an area of interest in regards to how artificial intelligence can support clinicians seeing patients. This is a system in which develops an answer to patients' questions, and this is actually how they test it. So there is a human here, and the answer for a particular question from a patient was given by a computer or by a doctor, and this human was trying to distinguish whether the answer is from the computer or from the human, the doctor, and they barely can distinguish between which one was physician, which one was AI. And another study, not only in ability to distinguish whether something is from a machine or something is from human, they actually also ask which answer is better and which answer is more empathetic. And this is the results. So these are the results. These are for the answers from physicians. They get to be graded as acceptable overall. But for the chatbot, which is the AI system, they were actually scored much higher, and they were deemed to be very good answers. Here in the empathic response, not really empathetic, mostly the physicians, very empathetic, the chatbots. So not to say that clearly the chatbot will replace us in responding to the patients, but I think they will have a role in drafting an initial response. And with that initial response, we can see it, we can edit it, or we can send it. So instead of having everything from scratch, these AI systems that I think will be available in the following year, they will be able to help us decreasing this burden of multiple questions and answers with our patients. So Dr. Torres is interested in research now because he's seen many patients with thyroid nodules and thyroid cancer. But he's lacking this infrastructure to understand how many patients are seen in the institution with thyroid nodules, with thyroid cancer, what are the outcomes, and so forth. And I have told you that this is a significant problem in our field. We don't have registries because they take a lot of time. But we can start developing what is called the virtual registries with AI technology. If we think about it, this patient, for instance, is producing a lot of information that is captured in different reports, like ultrasound, biopsy, surgery, follow-up, and these reports are in a way that we cannot easily extract information. But with AI, particularly natural language processing systems, we are extracting this information, at least the usable part, and we are assembling what we call the virtual registries in a way that if I were to interrogate these systems, for instance, this is actual data from our system, I say how many of the patients that we have seen over the last 3 years for thyroid nodules, how many of those in imaging are found by incidentally or without non-incidental in CAT scans, and among those 10% are found incidentally, what are the size, the location, other characteristics of the incidental findings. We can interrogate whether the ultrasound that follows is an ultrasound that was ordered appropriately or inappropriately. And this is actual data from our institution. We can interrogate, okay, what are the Bethesda from the cytology? For instance, from 3,000 cytologies that we have conducted over the last 3 years, this is our distribution, mostly benign, malignant, a good number of indeterminate results, and we can actually see how many of these patients had molecular testing and how many of these patients ended up having surgery, what had been the outcomes of that, so we can learn from our own practice. This is in regards to cancers. We have a system that runs the algorithm in pathology reports, and we can tell us how many patients are we seeing with high risk, intermediate risk, low risk, or very low risk. So what is it is important is because we can learn from what we're doing, but more importantly, this data will be put together in a way that supports the practice, and we are developing hopefully one helpful AI system that's called the Thyroid Navigator that pulls data from many of these sources, and it will be something like this that in which you are, primary care doctors, not really endocrinologists, because I think the endocrinologists with a thyroid nodule and thyroid cancer practice will not benefit as much as other specialties from this. But imagine that you are a person who sees mostly diabetes and you have a patient with thyroid cancer. You can actually interrogate the system and says that you can ask, okay, review the patient information and tell me the risk of cancer recurrence. The system will be able to tell you, okay, it's 20, 30% in the next 10 years, and the recurrence is more likely to come in the central neck or the left neck. So you can focus your attention on that, for instance. You can ask, should I use, for instance, any therapy for this patient? And they say, yes, thyroid hormone suppression might help in these circumstances and can reduce the risk of 2030 by 15 or 20%. And you can say, why you are not suggesting radioactive iodine? I can tell you that based on the system, what the system is learning, the tumor is likely to be a BRAF-like tumor, and it seems that it's going to be less likely that the patient or the tumor will respond to radioactive iodine. So it might help you with your decisions in a way that you have a kind of an expert next to you, not making a decision for you, but answering your questions about the patient that you are seeing. So hopefully serving the purpose of helping individuals, not experts for thyroid nodule and thyroid cancer management, take care of the many, many patients that we ended up seeing. And again, this has been a small summary of what we can do or what we will do with thyroid nodule and thyroid management. Of course, it's not extensive, but hopefully you have the gist of the potential of these tools to support the care for our patients. This again, my email, my Twitter handle, and feel free to ask any questions. Appreciate the invitation. Thank you.